Thank you again. So we're going to, now according to the agenda, we are going to try to have our deliberation and votes over the next 45 minutes. If the deliberation needs to take longer, we will. But I think we can script it so that we have plenty of time where we need it. At this phase, what we're going to do is start to move through some voting questions. We've brought the lead from the ICER team on the clinical review and the economic review up to the table to answer further questions. We have our patient representatives and clinical experts. So let's go back to it. What we need to do first is just to do some test voting questions to make sure that the technology, excuse me, is functional. So, Ellie, am I doing this? I don't know the answer, so maybe I'm the right person to do it. All right, I give full credit to Ellie and the team. Here's the question. St. Louis consumes more blank per capita than any city in the United States. It would have been more fun to have guessed what the choice selection would have been here, but the choices are iced tea, barbecue sauce, 7-Up, or donuts. So, again, the purpose of this voting question is not to make fun of St. Louis. It is to test the voting. So, what we're going to have is go ahead and enter your vote. And we have 12 voting members, and we will see already up to 11, so we have one more. All right, I can see it.
We only have 11.
We have one more person who hasn't voted, correct? Oh, we only have 11. Are we missing somebody? Oh, we only have 11. Apologies. Okay, so let's see what your votes say. You thought it was barbecue sauce. The answer is barbecue sauce. Very good. Very good.
Breakdown by CEPAC members who live in St. Louis.
Yes.
He's blinded.
I want to know why. I want to know why everyone knew that it didn't lead the nation in 7-Up consumption. That's an interesting feature. Okay, so we know how to vote. For the audience, you can see there will be 11 votes. And so when we get up to 11, that's when we'll be able to display the results. Here's the first set of questions. I'm going to read about the patient populations for them first. When we ask questions about rivaroxaban, it is in reference to a patient population that consists of adults with established cardiovascular disease who are currently being treated with optimal medical management. When the question is about Vascepa, the question refers to patients who are adults with either established cardiovascular disease or who are at high risk for cardiovascular disease and are currently being treated with optimal medical management, including statins. All right?
Can I ask
yes.
a question of Vascepa? I thought they had...
Sorry, we have to ask you guys to continue to use the mic so the web folks can hear you too.
On the Vascepa, did they not have to have diabetes, or did I miss that?
They did not have to have diabetes for the
high risk.
For the established cardiovascular disease population. Right. You can in the trial primary prevention. In the primary prevention trial, they had to be over 50, have diabetes, and one additional risk factor. Whether you view that that's necessary is part of the issue.
Okay. The first question is the evidence adequate to demonstrate that the net health benefit of rivaroxaban plus aspirin is superior to that provided by aspirin alone? Now, I know that you have your evidence summaries with the few key tables from the report, and I'll just ask David again to very briefly summarize those data and the basic thinking behind ICER when we gave our preliminary rating to this, to the evidence related to this question. David?
Sure. So if you look on page 3 of your evidence summaries, you've got the primary and secondary outcomes of COMPASS and leading outcomes of COMPASS. Just note that in that very first line there, the aspirin very first number of 448, 4.9 should be 5.4% and some other N. That's the rivaroxaban alone number, and that's not what we intended to show there. So it should be 4.1 versus 5.4%. The other numbers are correct. So you can see the 24% reduction in hard MACE. You can see the increases in bleeding. We talked through this. We ended up giving this a B+ rating, again, because of our concerns about how you trade off bleeding versus events, and what sort of events we're talking about, and what bleeding would look like in the real world.
Questions? Don.
Steve, I know I've heard you say this before, but with respect to the term adequate, evidence adequate, could you remind me and perhaps others about the guardrails around what we mean by adequate in this context?
There are very loose guardrails framed mainly by your own collaborative experience and perspective. These votes are obviously, they don't have any statutory or other power. They're meant to reflect your judgment that could be interpreted by payers, by clinicians, by patients, by all of the above. But it's not meant to specify whether it should or shouldn't be covered. That's not the implication. We're looking just at the evidence. Do you feel it's adequate? Because there's always uncertainty. We all always deal with that. The question is it adequate to demonstrate that rivaroxaban plus aspirin provides a net health benefit compared to aspirin alone? Jason,
One
go
of the
ahead.
things that I would just comment on, I think, COMPASS is an interesting trial for a number of reasons. I think one potentially controversial interpretation of it would be that in some ways it was a stroke prevention trial in people who had either coronary disease or high risk of coronary disease, right? I mean, this primary endpoint, we know from the analyses of the individual endpoints, was primarily driven by ischemic stroke. And MI was not significant. I think one thing I always find a little bit perplexing about the trials, as I recall, is that the death from coronary disease was different between the two groups, but MI was not. So that's always a little puzzling, because one would think if the deaths because of coronary disease, presumably because of MI, were higher, then one would think that MI would also be higher in the control group. But I think that one thing I struggle with as a clinician is that, so the decision before me is commonly, this person has had a myocardial infarction or has a high risk of myocardial infarction, how can I reduce the risk the most? And so to me, the biggest lesson of COMPASS is that I may very well be reducing the risk of stroke if I were to add rivaroxaban. I don't struggle with that in the setting of the question before you all, because net health benefit to me incorporates all those things. But
Steve, can I just...
Sure.
Because I think one of the manufacturers mentioned the ESC guideline. Stuart and I had actually been having this conversation this morning, and I did locate the recommendation from the ESC guideline just published, which is for high-risk patients with TG levels between 135 and 499.
I think you're looking at the Vascepa. That's for Vascepa. We're talking about rivaroxaban.
I'm sorry. Forgive me.
Jason, just real quickly, back at your question about the distinction between MI and cardiovascular death. Is it possible that this is preventing bigger MIs through through whatever mechanism you wish to ascribe to it? The directionality of the impact on MI is in the right direction. It's just not statistically significant, which would, again, one possibility is that it's stopping the bigger MIs, not the smaller ones.
yeah, I mean, that's probably the best explanation I've ever heard. I'm not saying you're right, Steve.
I understand. I think that was clear. Yes.
I think, I think that's entirely, that is one of the plausible mechanisms for sure. I'm trying not to be leading because I know I'm not the one voting and you all are, but I think I don't struggle about this distinction a lot because I find the stroke data quite compelling in the trial, but just kind of it's an interesting thing, is that so much of this, and that's consistent with what we would assume given the biology, just ischemic stroke in particular, the heterogeneity of causal pathways to ischemic stroke. It could be carotid disease, it could be atrial fibrillation, it could be aortic athero, it could be any number of different things, which is different than our traditional thinking about myocardial infarction, which is traditionally really focused on platelet biology. So I think it's just a curious thing. But I think that's a defensible interpretation of the results of this trial in clinical practice. Is that these patients with coronary disease or high risk of coronary disease are also probably at high risk of stroke, and it appears that rivaroxaban at low dose could reduce that endpoint substantially, significantly and substantially.
Right. Okay, I think you guys had a discussion around the evidence on this early that was probably largely adequate to answer most of your questions. So let's go ahead and vote on this. Again, A is yes, B is no. Is the evidence adequate to demonstrate that the net health benefit of rivaroxaban plus aspirin is superior to that provided by aspirin alone? And the answer is, 10 yes and 1 no. I think if we have real quickly, if the person who said no, we sometimes like to just make sure that the thinking is clarified. The person who said no, if you wish to describe your thinking.
Well, I just stuck to my guns. I think that the absolute difference is quite small. There's no certainty that that would be maintained over a lifetime. And the bleeding risk in the setting of a clinical trial is likely to be lower, maybe substantially lower than in real-world practice. So for all those reasons, I'm just on the edge about this and put my vote in the no column.
All right, thank you for that clarification. And we will return to the questions about risk stratification, shared decision-making when we come to the policy roundtable. The next question is similar. This is the one about, still on rivaroxaban. Apologies, we'll get to Vascepa with the next question. This one, though, says, is the evidence adequate to demonstrate that the net health benefit of rivaroxaban plus aspirin is superior to that provided by aspirin as part of dual antiplatelet therapy with an oral P2Y12 inhibitor? Here we are talking about, and actually is it ticagrelor? Ticagrelor. I just haven't pronounced that drug in a long time. Or clopidogrel. David, summarize again, please.
Sure. So we obviously talked about some of this earlier. Just to reiterate, we did look at patients in the first 2 years after an event, so first they had an event, and secondly, it was in the first 2 years. So we were looking at a subpopulation of COMPASS so as to compare apples to apples. Within that, and to the extent we could tell, if you look at the network meta-analysis on page 4 of your evidence summary, there are wide confidence intervals around the comparisons between those combinations, other than that the point estimate for the ticagrelor aspirin versus clopidogrel aspirin is 1. But for the versus dual antiplatelet therapy, both of those are 0.91 with wide confidence intervals, and we're not at all sure about the bleeding. We ended up, for that reason, both the wide confidence intervals and the lack of certainty that we could understand what was happening with bleeding, which is obviously a central issue in figuring out whether you'd rather have rivaroxaban plus aspirin or dual antiplatelet therapy, we gave this an I and said the evidence was insufficient.
Is there any further comment that needs to be made about the subpopulation for which this comparison is being considered, David? We've already talked about that a fair amount. Just want to make sure. Okay. Questions from the council? All right, please go ahead and vote. Okay, unanimous 11 no. All right, we will continue on. The third clinical effectiveness question is, now we are moving on to Vascepa. Is the evidence adequate to demonstrate that the net health benefit of Vascepa added to optimal medical management, including statin therapy, is superior to that provided by optimal medical management, including statin therapy alone? David, you're on again.
Sure, so if you go to page 5, you can look at the reduce it outcomes. Things to note on this question are that have come up in various ways. We're including statin therapy. We're not asking you to say would it work if these patients aren't taking statins? It was pointed out earlier that I misspoke. It wasn't 93% who were taking statins. It was 100%. 93% were on moderate or high-intensity statins. So everybody in Reduce It was on a statin. You'll note that the question doesn't say anything about triglycerides. And so that's a decision we were making not to include triglycerides in your vote. And as Don or Tim was suggesting, we didn't define high risk as necessarily diabetes plus age 50 plus one additional risk factor. We just said high risk. Some of this is an attempt to guess at how these drugs are likely to be used. It was our sense, looking at all of that, and with our biggest uncertainty being the multiple negative fish oil studies, but the positive GELIS trial, and much less concern, by me anyway, about the mineral oil. I think that if that was the case, it would only have had a small effect on blunting it, but I'm bothered by the multiple negative trials. Even with all of that, given the magnitude of this effect, it seems very unlikely that there isn't at least a small net health benefit, and so we rated this also as B+, small to substantial net health benefit, not including the possibility of no net health benefit.
Don, I thought you might want to tee.
I jumped ahead.
You're ready.
My triglycerides must have been high from lunch. So the ESC guideline that was mentioned actually does have a new recommendation as of August 31st, which I think relates to this, which is in high risk. And one could argue that the fact that there's been perhaps a major cardiovascular event at the start, that the patients are already high risk in some of them.
So that was two populations, right. The high risk and the cardiovascular event patients have cardiovascular disease, right. And we assume all those people have at least a 20% 10-year risk, and many of them much higher than that because that's well known. The ones without that were the ones where in the trial high risk was required.
So the recommendation is just briefly in high risk or above patients with TG levels between 135 and 499 milligram per deciliter. Despite statin treatment, Vascepa should be considered in combination with the statin. It doesn't say Vascepa, and that's graded as a 2AB, which I would call sort of a step below a strong recommendation, and B, moderate quality of evidence. So in some regards, having seen the letter from one of the manufacturers talking about high quality evidence, I think just to frame it, it's certainly not low or weak, but I think it's sort of in the middle, and I just add that in for additional information.
Scott?
Can one of the clinical experts
Scott, I'm sorry,
help me think through the much higher hard MACE event rates in this trial? I know they're not exactly the same patient populations, but there is a degree of crossover where we're talking about 5%, in the aspirin group versus 15%.
Different length trials. You're talking about Compass versus?
Yeah.
So Compass was 23 months. This was 4.9 years.
So in 2 additional years, we'd expect
they're actually
doubling.
The baseline rates aren't that different if you double. Yeah.
You're making like a proportional hazard assumption, basically. You're trying to extend that time based on that's what you're saying, right?
Well, if we don't think the events are happening at a steady rate in the placebo arm, that wouldn't be true. But if we don't think the events are happening at a steady rate in the placebo arm, we're in trouble generally.
Right.
So.
Other questions about the evidence related to Vascepa?
This thing with the...
Please go ahead.
Sorry, can I continue?
No, absolutely.
This thing about the sort of prior probability that this trial would have been, demonstrated efficacy is a real issue. Is negative trials and fish oil. I mean, as we've discussed, there are plausible reasons why the dose was different. The EPA DHA ratio was very different. But I was in the room when this was presented at the American Heart Association, when this was sort of presented to the cardiology community. There were gasps in the air. I mean, people were shocked, including me. I think when this was presented, that after so many negative trials, that there should be such a positive trial with a pretty big effect estimate difference. I mean, it's not just a little bit positive. It's a pretty big difference.
Yeah, I mean, I actually recall similarly when I think there was a press release maybe from Amarin about the results being positive and talking about something about the results and people like me and everybody else kind of poo-pooing it, waiting to see the real numbers and not thinking there'd be a mortality effect or anything else. And then these came out and it was like, wow. So, I mean, we were pretty stunned by this set of numbers.
The fish oil hypothesis was nearly dead.
Yes. Yeah. I had been telling patients it was great they were taking fish oil, but they could just give it to their cats.
Do you think so? One question, or for me on this particular topic is I have discounted the prior literature around fish oils in this particular, in my assessment, or trying to answer this particular question, in part because I kind of believe the product is different. But is that? I mean, because like when you.
Question.
Okay, that's the $1 million question. All right.
If we didn't have.
Yeah, because you should look at this and say, like, well, I mean, like, it's one. If you think all of them have are testing a comparable product or a comparable intervention, and it's 1 out of 20, I would look at that and say, well, that's like, as an analyst or an analyst, like, it's a spurious result. Like, I'd like to see another trial. The problem is, I'm not going to see another trial with 9,000 patients in it.
If we didn't have the Jealous trial, I would honestly. I'm not sure I could have defended a B+ on this. The Jealous trial was in a population that shouldn't have gotten as good a response as the population, because it was a Japanese population already with lots of fish oil in it. And it shouldn't have gotten as good a result as seen here. And it got quite a good result relative to all the other fish oil studies, and it was another EPA-only study. And so I don't think it's entirely fair to say all the other studies and this one, it's a whole bunch of other studies and this 1.5. And that half alters my priors enough that I think the B+ is fair.
Thank you.
Greg and then Tim.
As I recall, David, the Jealous was an open-label trial, and there was concern about that trial.
Yep.
But I think there's less concern about the Vital trial, which was published nearly the same time as Reduce It. And I agree it's a different composition of fish oil, but that trial was thoroughly negative. And that's not an old trial. That's a concurrent trial.
Tim?
Thanks. That's helpful. And I raised it before, but once again, is there any strong evidence or convincing evidence or any biologic plausibility about the DHA harm effect? I don't see it or hear it or know it, and certainly the other 20 trials didn't think so. But
yeah, there was just a statement made, maybe by AHACC? By the AHA, saying that there had been beliefs that DHA raised LDL and had negative effects, and that when they looked at this, they weren't convinced that was true. So, no, I don't think we know why EPA should work and DHA, EPA shouldn't. But remember, nobody has given this dose of EPA in any of the other trials. That's not a thing you don't have to assume DHA to be harmful. You just have to believe that you need this dose of EPA to be beneficial to get a different answer. But, there are lots of drugs we use where we're not sure why they work. I'm more, aspirin. Why exactly does aspirin, how does statins prevent MIs? We've got a cardiologist. How does statins prevent MIs? And why does that happen within the first 2 weeks after taking a statin?
Sounds like you don't believe in the LDL hypothesis.
I don't believe in the LDL hypothesis is the explanation for that.
But was the AHA statement before or after this trial?
It was after.
So they went back and kind of said, here's the data, I'll go figure some reason out why.
No, the AHA was saying, don't believe that it's damaging. The AHA was saying, we don't think that the AHA was saying, people have been arguing that the explanation is that DHA is bad for you we don't think there's evidence to back that up.
And on the vital trial, it was 1 gram as opposed to 4. So
I think the vital trial, so we were discussing before the fact that somebody decided to do this study, right? As an explanation that, gee, there must have been a good reason to think this would work. The vital trial is sort of an argument for people seem to keep doing studies of fish oil, even though you'd already proven it didn't work. So I don't know what to make of that.
Greg.
I know that vital was a lower dose, but here again you're talking about kind of eye-popping differences in outcomes, and you have to believe that that dose really made the difference, plus the composition. So,
is there any phase 1, phase 2, any other data that suggests that the dose is in some way producing a graduated effect, or do we just have this no effect, big effect data? Is there anything at all?
Jealous wasn't this high a dose. The Jealous trial wasn't this high a dose. It was in between in terms of effect. As pointed out, there were problems. It was an open label study, but on hard endpoints, it showed an intermediate effect.
Okay. Stuart?
no.
That's what I thought. Okay. All right, let's go ahead and vote, please. A is yes, B is no. Is the evidence adequate for Vascepa over optimal medical management with statins? All right. We have 9 yes and 2 no. For some reason, I think I know where the no's. I have a confidence interval around where the no's were. And I have a lot of precision in that confidence interval. I think we've heard the rationales behind it, so I want to keep going. We're going to talk about the potential other benefits and contextual considerations, and then the long-term value for money. So first you will see potential other benefits or disadvantages of rivaroxaban, then the same set of questions for Vascepa, and then we'll turn to the contextual considerations. So this is a set of potential other benefits or disadvantages. Does treating patients with rivaroxaban plus aspirin offer one or more of the following potential other benefits or disadvantages compared to treatment with aspirin alone? A, this intervention will significantly reduce caregiver or broader family burden. B, this intervention offers a novel mechanism of action or approach that will allow successful treatment of many patients for whom other available treatments have failed. C, this intervention will have a significant impact on improving patients' ability to return to work and or their overall productivity. And D is an open fill in the blank. Are there other important benefits or disadvantages that should have an important role in judgments of the value of this intervention? Let me just invite the patient representatives again. You've maybe commented somewhat on some of these, but anything in particular jump out at you as an important potential other benefit or disadvantage that you'd like to comment on? No pressure. That's fine. That's okay. Any questions or ideas from the panel on these? Anybody have a particularly strong feeling, yes or no, on any of these that they'd like to share with the CEPAC before the vote? Okay. All right. Now, this is a vote all that apply. So I'm not going to know when you're done until you're actually kind of looking up at me. That means that you're completed with all the voting. So vote A, B, or C. Since no one has raised a D, there shouldn't be any Ds. Just to make sure. Yes, Jill. Oh, you want to raise a D?
Yeah.
Oh, okay. It's best to discuss it because you may have others who want to jump in on it with you. So go ahead. I'm sorry. Go ahead.
The increased bleeding risk in a clinical trial population, when it's extrapolated to real life practice, I think that we may be underestimating the bleeding risk. So it could be a disadvantage.
Okay. In some ways, that fits more with the net health benefit issue, which is kind of in the core clinical effectiveness consideration. These are supposed to lie outside of that.
Okay.
But I think what you're saying, we want to capture, maybe we want to capture it as a comment on the clinical effectiveness. You still voted that there was a net health benefit, but you want to clarify that there might be some generalizability issues around that. Okay.
Just to note that when we get to the contextual considerations,
Yes. Oh, that's there
there's a
too.
vote about uncertainty
That's right.
of harms.
That's right.
So, okay.
So just,
We could
you're
put
going
it
to be
there,
voting
too.
in a moment on compared to the comparator, there's significant uncertainty about the magnitude or durability, long-term benefits. There's a significant uncertainty about the long-term risk of serious side effects. So maybe vote on that on contextual.
Although I want to make sure we capture what, we could do that, and this is, I think, more about generalizability, that the population averages found from this one trial obviously do not fit every individual patient or any individual patient, and so that risk of bleeding may change given the individual patient when treated in the real world. Go ahead.
I guess just clinically, I think that as we've discussed previously, a lot of when we deem a patient at high risk of recurrent thrombotic events, we often make the decision to put them on dual antiplatelet therapy as opposed to aspirin alone. That's a very common thing. We trade off thrombosis and bleeding risk and make that individualized decision. Conceptually, there's some situations where people can't tolerate that medicine. So people have dyspnea with the ticagrelor, or bleeding with. I mean, there are 3 major antiplatelet agents in addition to aspirin, and usually we can find one that is tolerated. But I guess there conceptually could be patients. I'm relatively convinced about the comparative clinical effectiveness of rivaroxaban low dose versus aspirin alone, but I think what's so confusing for us as clinicians is the comparative clinical effectiveness and potential harm of DAPT versus aspirin versus rivaroxaban. I guess this gives you more options. I don't know if that counts as a...
That counts as an excellent policy roundtable question.
But does that count toward B, for example, which is this is a novel mechanism, an alternative pathway, a different use to kind of get to the same risk reduction. It's a different mechanism in comparison to the alternatives, right? That is the theory of like widening the treatment options available to cardiologists and patients is of benefit, especially since we've established in another question that the majority of folks said that there was net benefit.
Mm-hmm. Okay. I'd take that. Yes, Don.
Yeah, I thought about D and just wondered about the increase in complexity of adding one more drug to a regimen, the lack of clarity on shared decision-making, especially related to cost, this non-significant finding, which I found weird, of increased bleeding. These just raise questions about how easier it will be, if at all, for a patient to add one more drug.
I think, yes, and we are going to talk about that also in the policy roundtable. As far as a specific disadvantage for this one drug, I would counsel caution in assigning that burden to just the last drug in the set. You could say it's equal for any of the drugs for which we have the option of treating. So I'm not sure I would assign this particular drug that special disadvantage of being last on a heap of drugs that's already too many for a single patient to take or something like that. So we'll talk about it. It will be part of the discussion, but okay, then let's keep D off the list for now and just vote A, B, and C. And some of you are probably already done, or maybe many of you are. But actually, I should see at least 11 up there, I think. No? No, that's right. They don't have to pick anything. That's right. Sorry. So I'm just going to look at you, and when you're looking at me, I can tell many of you are done. Okay, so it's just a few over here. Eric, you still voting?
Nope, I'm good.
Then look at me. There we go. Okay, I think we're done. You were so done that you were answering your email. All right, here we go.
I was waiting for the rest of you.
All right, we had 1 voting for A, 6 out of 11 voting for B, and 1 voting for C. All right, let's move on to the Vascepa potential other benefits or disadvantages. Now, I know this is, in some ways, seems odd because we're asking you the exact same questions about the kind of a drug in the same general space. Obviously, we're not saying that these 2 drugs are used in the same patient population. Are you seeing that? No, I guess not. The connection for mobile responses has been lost, I'm being told. I don't know if is there a way to reboot that, or are we just going to have to fly blind? All right. So for whoever owns our server issues, if there's a way to try to resurrect that, it would be much appreciated. Okay, in the meantime, I swear I didn't touch it. Okay, but we wanted to go ahead and have these votes separately for both drugs, just in case there was some particular difference in the way that you thought it might affect caregiver burden or ability to return to work, or the idea of a novel mechanism of action. In a sense, they're both new mechanisms of action in this general space. Any other questions or comments, though, before you vote on these?
I don't.
Okay.
I can't.
What we're going to do for voting under this circumstance, which we will do with your approval, would be to go ahead and do hand votes. Does anybody feel uncomfortable with that? Okay. So we will continue to try to get this back online, but in the meantime, I'm just going to go A, B, C. So if you believe in this, that for instance, A, this intervention will significantly reduce caregiver or broader family burden, you will raise your hand when I ask for that vote. Okay? So, all in favor of A? 0. All in favor of B? 1, 2, 3, 4, 5, 6, 7. All in favor of C? 0. All right? Those results were very similar to the ones for rivaroxaban, so let's move on to the contextual considerations. Any chance that we're online or no? Oh, sure.
Could you go back one? I'm struggling to figure out how people can vote for. Could you go back so I tell you what my struggle is? How can we say that it's B if we don't think it's A or C? It's not just novel mechanism of action, it's also successful treatment. So shouldn't, if you voted B, have to vote A or C?
So I'll answer how I thought about that particular problem, right? Which is, in this particular treatment, I did not see the impact on caregiver or family burden, given the condition, to be that substantial. So it's while there is some benefit, and it might be reflected in the societal analysis, I didn't think that it was something that we hadn't quite covered in other analyses that we've done. I felt like it was appropriately reflected in other analyses in the way we captured either quality of life or the societal perspective in other evidence presented today. So that was my thinking on it. I don't know if that is...
And the same way with C as well?
Yeah, exactly the same thing on C as well.
Okay. Maybe I'm interpreting A and C.
Well,
that's just my take. I don't know, Tim.
Historically, I can also share that there are different people will approach their voting on this differently. Some will want to see evidence, and others will take a kind of input or hunch or stories in different ways. One way to think about A, for instance, is also in the historical context of the other conditions that CEPACs have heard about before. So if there's a very disabling condition that among children for which the entire family has a huge burden of care, they might have that in their minds while they're also thinking about other conditions, which clearly have some impact on the family, for sure, but may not have as significant an impact that it needs to be taken as something kind of uniquely important. So, and the same with returning to work. Here we have a modified societal model that tried to incorporate that effect, and it had very minor change on the results for cost effectiveness. Some people would pay more attention to that and some less, but that's just some of the way that people have thought through these. Tim?
I would agree with both those comments that were just made and Eric's comments, and I am an evidence-driven person, so I'd like to see the numbers as well. And I am hung up on the words will significantly, so I have to see will and significant in order to vote yes. So
Right. And CEPAC, like the rest of the public, is aware that we have proposals on the table for changing the way we do these votes on these potential other benefits for early 2020. So we'll look for your input as well as others. But some of these difficulties with figuring out what to weigh and how to put it into perspective is as we continue to evolve, we hope to get an even more kind of calibrated, precise way for you to think about these. Okay. I think we are moving on. Right, we're moving to 6. Let's hope. All right, so now we're into the contextual considerations. So contextual considerations that you think are important to send as a signal, in a way, to all those who would be assessing the long-term value for money at current pricing for rivaroxaban plus aspirin. A, this intervention is intended for the care of individuals with a condition of particularly high severity in terms of its impact on length of life or quality of life. B, this intervention is intended for the care of individuals with a condition that represents a particularly high lifetime burden of illness. C, there is a significant uncertainty about the long-term risk of serious side effects. D, there's significant uncertainty about the magnitude or durability of the long-term benefits of this intervention. And E, is there anything else that you think should have an important role in judgments on the value? Okay. Any thoughts on these contextual issues from your perspective? We're talking about rivaroxaban. We'll have the same set of questions about Vascepa in a minute. How are you thinking about severity, for instance? It's a question. Is this a severe condition in terms of its impact on length of life and or quality of life? Anybody want to say, I'm going to vote yes on that one because I think it is ... or no ... Don?
Well, I mean, simply put, people with serious cardiovascular disease, I mean, that's the way I look at that. So maybe that's not correct, but I think it's, in my mind, relevant.
Okay. Jill, anybody? Eric?
Well, I do. I mean, on A, I do think it is severe. I'm not going to choose A. Not that I'm not opposed to. I mean, I understand anybody who would. My inclination is on D, where I believe there's significant uncertainty about the magnitude of the long-term benefit, and I think that's expressed. It's been expressed multiple times per day, but the relative absolute difference is just, I think that as we see more studies come out and testing this particular medication, that durability, or I should say the magnitude, might get challenged, or it might be increased by additional evidence. So I look at uncertainty regarding the magnitude of the benefit.
Any other questions or comments? Stuart?
Likewise, on the possibility of longer-term serious side effects, if you look at any bleeding risk calculator, things change with age, things change with the addition of comorbidities, and so I think that's very relevant for a patient who initially is started on rivaroxaban. Maybe 5 years later, their bleeding risk is substantially different, at least on paper.
One of the trickiest things in cardiology is this risk of bleeding and risk of thrombosis.
Can you grab that mic even closer?
One of the trickiest things in cardiology is this trade-off between risk of bleeding and risk of thrombosis. In most cases, in most situations, both in terms of the antiplatelets and anticoagulants being considered, but also the clinical profiles of the patients that are high risk of thrombosis, and as such, you'd get out of this problem that's been very eloquently the small effect of the people who are at higher risk of thrombosis conceptually probably have a better benefit of the therapies. They're also at higher risk. There are some things like age, make you higher risk of thrombosis and higher risk of bleeding. So the decisions we make are very much around these relative risks. There are some, if someone's had a history of intracerebral hemorrhage, that probably doesn't increase their risk of thrombosis,
right,
but it sure does risk the bleeding. So that makes us really stay away from the anticoagulants and the antiplatelets as much as possible. But this basic problem is a big, tricky thing because you could flip what you said around, right, and said, you guys are all, and I get it, you're uncomfortable with the small the small effect, the small absolute effect.
Yeah.
But one would think in those high-risk bleeding patients where you're also more worried about bleeding, you also might actually have a bigger absolute effect. I know what I'm saying is speculative, right? You wouldn't know that for sure, but conceptually, people at higher risk of the bad thing are more likely to benefit in terms of absolute
It's the same thing with the discussion around atrial fib. Same thing. There's an overlap between Chad's VAS
and Hasbled.
and Hasbled.
Exactly.
Three other factors. Right?
Exactly. It's the same thing. And then there are scores that can disentangle these things, but in general, these risks go together, unfortunately.
Right, and I totally agree with you. But the evidence in front of us right now doesn't. We can't address that with the evidence we have, and so that's why I flagged through my vote this idea of significant uncertainty regarding that point.
Yeah, that's very reasonable.
Well, I want to just offer as a possibility. I don't want to, because I'm moderating. I don't want to make you guys do this, but I do want to recognize the possibility that as a contextual consideration, when we talk about the net benefit, this is getting almost back to Jill's point. You can call it uncertainty, but this is one of those situations. For some drugs, let's say there's a 20% chance of diarrhea, and you just don't know who's going to get diarrhea. People do or don't. It's 20% of them will. Here, coming into the clinical decision-making, you might, as a clinician and a patient, know that you're at higher risk of a bleed. You've stumbled and fall, you're unsteady on your feet. There are other aspects that can be weighed into a shared decision-making process that will change on the spot your chance of having a net health benefit from a certain treatment, which is different sometimes than other treatments where the risks are again, much less, you're not able to stratify patients in the same kind of way. So it's not always easy. Sometimes these risks and benefits track together. But I know that clinicians and patients, and I think payers and others, should remind themselves contextually that this is one of those situations where there is a variable kind of Bayesian almost probability of benefiting and of gaining harm that needs to be taken into consideration in the use, coverage, pricing of this drug. Would anybody else like to suggest that as a contextual consideration? Or not, but it's been said, and I think we'll capture it in one place or another in the report. This could be one of them. Rachel?
So I'm thinking about whether the size of the patient population matters.
Is a contextual consideration?
Here, and I'm trying to decide how I feel about it. So we've had a number of issues that we've considered as a CEPAC where something like cystic fibrosis was in my view a particularly high lifetime burden of illness,
right.
But the patient population is much smaller than we have in this kind of situation. And so here it may be a high burden of illness, but may be constrained to a particular period within someone's lifetime, or may in general, not always onset later, but because the aggregate number of individuals involved is so much larger, is there a way to think about the impact of that here? And I know we're not voting on budget impact, that's
right.
Not part of the analysis. I just wonder, and I'm not sure about this, if that is an additional contextual consideration that matters here. It certainly matters to the extent that we want pharmaceutical companies to be investigating drugs for conditions that affect large numbers of people. That would probably be a very good thing. Mm-hmm. And yet we've often considered drugs for very small numbers of people. Mm-hmm. And so I want to suggest that that's something I care about, but I don't know how to fit it in this analysis.
I don't either, because it's impossible to ignore the context of the size of the patient population, but it runs in different directions. It's the potential to do good for so many people, or the potential risk that we might be, throwing out to the public where we don't have perfect information yet. Again, and you mix in with that some concerns around the cost or not. We do try to handle the cost, in a sense, separately from this set of contextual considerations. So we could say that an additional contextual consideration is the potential size of the population, but that would probably be interpreted differently by some people as an advantage or a disadvantage.
In prior conversations, Rachel, we've also surfaced this issue of equity and health disparities as it pertains to certain conditions, and we haven't had a discussion today around what the evidence is in these particular trials of the efficacy of these drugs as it pertains to African Americans who have a significantly larger burden of illness of cardiovascular disease. And I don't know the kind of the pathophysiology as it relates to racial issues in this particular case, but that's something that we have historically as a group tried to raise and surface, to the extent that a particular treatment would either help reduce racial disparities, or in some cases we've arrived at conclusions where we thought that the treatment might exacerbate them, interestingly enough. And I just think it's a good thing to put on record, and I know we've had just some really thoughtful folks on this CEPAC that have been very aware of these issues, and if anybody wants to, I think, get them into the record, so to speak.
Yeah, so I'm happy to vote for E then, and to say that, because E is phrased very neutrally. It says it's a contextual consideration that should have an important role in judgments of the value, but it doesn't say in which direction that should weigh, and I think the size of the patient population does have both of these effects at the same time. So that's something that is both heartening and concerning to me, but something that we don't maybe have quite as much evidence or even intuition about as I might like.
And I want to support Eric's comment too, and speak up for Ryan, who's not here. And I think Ryan would have made that point as well, but I always agreed with Ryan about the point about disparities. So in that spirit, I'll probably also support that,
including the fact that there was only 1% black in the Compass trial.
Right.
So I'm down. Go ahead.
Steve, if this is not the right time or place to bring this up, I can kick it off. But what's striking to me about this whole evaluation that we've done is that probably the most impactful effect on major cardiovascular disease is lifestyle modification. We haven't even talked about the relationship of the drug therapies to how that might enable or impact lifestyle modification, and I'm thinking of the 6 evidence-based 1A recommendations. You don't need to list them because I think you know them. But I'm struck that we're talking just about drugs in terms of, and a little fish oil in terms of impacting adverse events. And maybe this isn't the place for it, but it just seems, the fact that we're silent about it is disturbing to me. So I just put that in there.
Well, if it helps, again, we're not here to create a guideline for what should be done first, second, third, or fourth. We are just trying to grapple with the innovative treatments as they come through the FDA and what to do with them in some sense with the evidence. So, I mean, your point's well taken, that no one would want to talk about cardiovascular disease without talking about diet, exercise, and other aspects, but it kind of lies outside of our purview right now. Okay, I'm going to make a suggestion then that we accept by acclamation an E, that the size of the population and the impact of these treatments to address potential disparities in care should be part of the contextual considerations that people should take into view when judging long-term value. And I don't think we have to vote on them separately. I'll just say that I'm sensing that people would be comfortable including both of those as things that the council had favored. Otherwise, why don't we go ahead and vote on A through D, and then we'll have our value votes, because we have to do this actually one more time with Vascepa, the contextual issues. So go ahead and vote on all that apply, A, B, C, or D. Sorry, what? I know. I'm sorry. We're going to have to do the same. Sorry. Yeah, we're going to have to do the same by hand. No, it's fine. What? Okay. Are they able to vote or not?
They cannot right now, but I could fix it.
Oh, we can fix it. Okay, go ahead.
Oh,
Yeah,
Go ahead.
perhaps.
Just a second.
See? I'm gonna do it. There we go.
Are we live?
Yes, sir. All right, you can try logging in again with the passcode.
Yeah, let's do it. It works.
Yay, Steve.
right, if you're in, go ahead and vote. A, B, C, and or D.
So are we supposed to vote for E even?
No, E is by
That's off the table.
E is by acclamation.
We already did it by
Yes.
acclamation.
God, so that means take it off
Yeah.
quicker.
Okay, we've talked about it quickly. Anybody still voting?
I'm still voting.
Okay. Okay, here we go. Ta-da. 6 for A, 6 for B, 9 out of 11 for D, sorry, for C and D. Okay, great. Let's keep going while it's still working. And we're going to do the same questions for Vascepa. I'm going to try not to touch anything. All right, I will, again, through acclamation, say that the same two issues should be considered. And if anybody has something different they want to say about A, B, C, or D, put your tent card up. Otherwise, please go ahead and vote.
I'll mention that we raised concerns about the effect on fisheries. Not that we were
Oh,
sure what they
environmental.
were,
I was
but
going to
we
bring it
raised
up in the
something
policy.
about
All right.
concerns
All right.
on
Don't.
fisheries.
All right. I'm just going to, if we have time, I'll talk about that in the policy
Okay, fair
roundtable
enough.
because it's a fascinating contextual issue. But probably, yes.
So the
Tim,
one
sorry.
other aspect I wanted to put in about this one was, in my opinion, the vagueness of the term high risk. I think it has the potential to be widely interpreted and implemented, and therefore go to a really large population. It's not just folks with diabetes and an additional risk factor. It's, as it was phrased, I think it was high risk or something like that. But regardless, if it moves beyond people in addition to just diabetes, the implications are very large.
Just trying to figure out if we should try to highlight that as an E that people should vote on. Some people have already finished their voting, right? No?
I will say that in the cardiology world, high risk is usually viewed
That
at
plus.
about the level of the baseline risk of the REDUCE-IT trial. Very high risk is typically people with known cardiovascular disease and ongoing risk factors, and high risk is usually people who are about cardiovascular, who have cardiac risk equivalents, so 20% over 10 years or higher.
Yeah, so basically everybody 80 and over.
Well, but in this context, people 50 with diabetes and one risk factor, some of those would be lower risk than what is usually viewed as high risk. High risk isn't a low bar compared to the trial.
That's my
Let's come
concern.
back, because again, this will be critical to our discussion around the coverage policies and clinical decision-making when we get to the policy roundtable. Okay, go ahead and vote, please, if you haven't finished your voting. A, B, C, and or D. Is everybody done? Okay, there we go. 6, 6, 5, and 7. Okay, so slightly lower vote on the uncertainty about long-term side effects for Vascepa versus the other one, the other vote, just comparing those two votes. Okay, thank you very much. That's meant to help round out our thinking and discussion before we take a couple of votes on long-term value for money. So we're going to take 2 of these votes. The first, given the available evidence on comparative effectiveness, incremental cost effectiveness, and considering the other benefits, disadvantages, and contextual considerations, what is the long-term value for money of treatment with rivaroxaban plus aspirin versus aspirin alone? And the choices are low long-term value for money at current pricing, intermediate, high long-term value. Brett, real quickly, the ICERs and...
Yeah, if you look at Table 7 in your evidence summary, that is, as Steve just put it, rivaroxaban plus aspirin versus aspirin alone, and you'll see the incremental costs and both effectiveness measures are primary that you're voting on is the far right, $36,000 per quality adjusted life year gained.
Actually, I just realized something. In our own methods, we state that if the base case is below 50,000 per quality, it's automatically high value. We should have already recognized that.
I wasn't going to
coming
correct
in.
you.
I know. And and we talk about the potential other benefits and disadvantages, and contextual issues is sometimes a way to give broader perspective if the numbers are higher. But I think at this point we can take that as our method. We should stick with it. So this is deemed this is deemed high value for money at high long-term value for money at current pricing. We are going to, there you go. You guys all already were there. Now, we're not going to vote on the next one, which was to compare rivaroxaban plus aspirin versus DAPT with clopidogrel, and that's because you voted that the evidence was insufficient to demonstrate superiority. And 10, which was Vascepa, also the base case cost effectiveness. Just remind me, what was it again?
It was 18,000 per quality adjusted
18,000 per quality adjusted life year. All right, so the next time someone says it's impossible to get below 50,000 per quality in the U.S., we've had 2 examples today, both for large populations. So we'll have a lot of fun talking about the clinical aspects and applications to coverage and pricing.